Good afternoon, ladies and gentlemen, and moderators. It's my honor to be invited here. And Professor Asai presented very clearly and beautifully the current situation of the Japanese OPCAB and overview of the VeriQ C. I will make talk about how I use VeriQ C case by case and how I found the efficacy of the VeriQ C. I'll skip some of the slides, so no disclosures. Okay, I skip these slides as the same concept as Dr. Asai showed. So what we need is intra-operative validation using VeriQ C. So I'll show you the case by case. Intra-operative direct coronary scanning. So before the anastomosis, start target coronary evaluation. So what can be detected? Intramyocardial lesion, very clearly detected. And when there is a septal perforator, you can see the septal perforator, because during the op-care procedure, you put the purse string sutures, you can avoid that kind of injury to the septal perforator. And if there is a calcium plaque, we can easily detect it. So this is one case. The location and depth of the target coronary artery is easily recognized. So I can avoid the unnecessary dissection for this case. For intramyocardial LAD, for the coronary angiogram, it looks like it's intramyocardium. It's actually intramyocardial LAD, almost near to the right ventricular cavity. In this kind of cases, you can avoid deep dissection and accidental right ventricular rupture. So in this case, I selected anastomosis site distally. If there is a local calcification in the mid portion of the LADs, sometimes I wonder I should skip anastomosis or make a small onlay patch anastomosis. In these cases, I checked the configuration of the coronary artery, and there was a calcium plaque in limited region, and I made an anastomosis of using a LITA short onlay anastomosis. For this case, local calcium is a dense calcium plaque in only the posterior wall. On the other hand, the coronary angiogram shows in which side of the wall of the calcium is located in the coronary arteries. So this is only the posterior wall calcium. So I made an only patch anastomosis using a LITA for this case. Okay, and when there is a long calcified lesions, so start scanning the one side. See, the proximal LAD, it's a little bit intramyocardium. This must be a tall part of the anastomosis. And then see the middle, gradually moving to the probe to the distal. Then you find some calcium plaque, and then you find another calcium plaque, and the distal LAD is okay. So finally, I make the reconstruction of more detailed images of target anastomotic site before coronary incision. Like for the mitral valvoplasty, you scan the mitral valve and make the images of the mitral valve before you start repair. So before start incision of the coronary artery, we make this kind of pictures. So then we get an adequate anastomosis. In this case, I made a long onlay patchplasty. This is some kind of pitfall of the diagnosis. It looks like there is an osteostenosis right coronary artery. It's suspected, but uncertain. It sometimes happens. So I think this is one kind of pitfall of diagnosis. So for this patient, I checked just the orifice of the right coronary artery. I found mobile calcified plaque over there. And pulse waves shows the restricted right coronary artery flow. For this particular cases, I did aortic valve replacement also. So I opened it, and I found that calcified plaques, it was detected by the VeriQ C. So I put on the saphenous vein to right coronary artery beating heart on pump before AVR, and then put cardio pressure infusion through the graft. Okay. This is redo cases. The other surgeon did this case, and the IT was occluded, and there was CTO of LAD, and I can't find the actual luminal of the LADs. So as Dr. Asai showed, the short axis scanning showed a very nice view of that graft. Let's see if I stop this. See. This is okay. This is occluded LITA, and this is LAD. And then gradually scanning it, this is some kind of thrombosis over there. And this study, very small caliber, but there was LAD. And for the longitudinal view, shows like this. Okay, and for this patient, location and the patency of target distal LAD was confirmed before arterial incision. This is another case of redo cardiac surgery. Actually, all of the distal anastomosis was patent, but unfortunately, only the proximal LITA was occluded by the Y composite graft, because it was a CC bypass actually, and the patient got a new LMT lesion, and I have to put another graft distally. In this case, the target distal LAD was easily recognized by using VeriQ C, and could avoid patent graft injury and unnecessary dissection. The validation of anastomosis and graft. This is a typical case of the side-to-side anastomosis. I prefer side-to-side anastomosis LITA to LAD, so you can measure the length of anastomosis and the caliber of the LAD and LITA. You can check it. And if I compare with the different modality, the VeriQ C provides much better and much precise configuration of the anastomosis, which cannot be detected showed by the coronary angiogram or coronary CT. And more interestingly, if I precisely look at the flow pattern using Doppler flow mappings, so the blue color shows the diastolic phase forward flow, and during the systolic phase, a little bit of blood is coming from the LAD. So this is another scientific view of using VeriQ C. And when I put the long-only LITA to LAD anastomosis, I check the anastomosis. 2D echo shows looks nice, and the Doppler color shows nice flow. And then I check the two part. It looks like good. And also the color Doppler shows good patency. And I can finish the anastomosis. Okay, this is a very interesting case. See, it looks like the appearance of graft is okay, but during the anastomosis, actually, one of the residents take down the LITAs, and I found a little bit dissection over there. But anyway, I sutured, and then transit time flow metry showed a little bit. For me, it's unsatisfactory graft flow, but the PI is okay. Actually, the flow pattern is acceptable, but when I checked it, this is amazing, because there was the dissection in just at the anastomotic site of the LITA. This is shield lumen, and if you see the short axis scanning, you can find like aortic dissections very nicely. I've never seen this kind of pictures, but VeriQ C shows very precisely of the dissection of the LITAs. And the flow mapping shows the actually restricted flow pattern in true lumen. So finally, I revised. I made it, because the length of the LITA was shortened, so I made it a free graft and made a graft revision. Got a nice flow, finally. For the intra-operative epi-aortic scanning, if there is a calcified aortic wall, the view is like something like this. And if there is a diffusely thickened atheromatous intima, you can find it, and more precise configuration of aortic wall, it is superior than to plain CTs. If there is a soft plaque, VeriQ C can clearly show it. And such a kind of soft plaque cannot be detected by plain CT. So for this particular case, 81 years old, emergency OPCAV cases, I found soft plaque, and there's some kind of small calcification over there. So VeriQ C enables proper selection of proximal anastomosis site. So I introduced for VeriQ C for other cardiac procedures. I found different potential of VeriQ C. See, this is a case of acute aortic dissection. The CT shows it looks like there is a coronary artery disease in the LAD and right coronary artery. But because this case is emergency, we didn't perform the coronary angiogram. So during the operation, I scanned it. Then I found the stenotic lesion in the LAD with calcium plaque. So I put CABG to LAD. Then I checked the right coronary artery. When I feel the outside, it's stiff. But I checked it, it actually, there is a calcium, but it's not stenotic. So I skipped anastomosis to right coronary artery. I think maybe this kind of procedure is applicable to the donor heart or the heart transplantation. If you find anything, any bad things, if you feel any bad thing for the heart, maybe you can just scan it, coronary artery, then you can find the patency of the coronary artery and not unnecessary discarding. Avoid unnecessary discard. So, and this is another interesting case. This is a coronary artery fistula with giant coronary aneurysms. You can see the inflow artery and the coronary aneurysm. And this part, there's a tortuous arteries. And I have to ligate this fistula. But there's a dense fat over there, so I can't find this, what is the exact fistula artery. Then I scanned it. Then short axis scanning shows the exact position of the fistula over there. And finally, I could easily find it and ligated it, and the patient is okay. This is the accidental retrograde dissection during the operation. The VeriQ C is easily shows that that's accidental dissection during the operation. And for the recently, total debranching TBI is our practice. But this patient got the previous bypass of the LITA and the radial artery to the obtuse marginal and the saphenous vein graft to the right coronary arteries. And because there's a very limited landing zone for this part, we put stent here and we put another debranching graft over there. And after we positioned the stented graft, the angiogram did not show the patency of the radial artery graft. So I wondered whether I should revise the radial artery or not. And then I checked step by step. If I scanned here, you can see very clearly the stent graft over there. And for the landing zone of the major curvature side, a little bit tiny blood is coming to the graft, but it's okay. And I can confirm the proximal saphenous vein graft patency. And then for the minor curvature site, a little bit space over there between the aorta and the stent. And then finally, I found the patent graft of radial artery. So there was no necessity to revise the radial artery graft during the operation. The patient was okay. And then this is the last case. this is a very unusual case of the malignant cardiac tumors, 49 years old male, and for with the right ventricular tumor. The VeriQ C showed very clearly where the tumor is attaching to the free wall of the right ventricle and where is the space for to make an incision. So I made a precise portion, precise incision to avoid the accidental cutting into the malignant tumors, and I took it. Okay. So in conclusion, intraoperative direct ultrasonic scanning with VeriQ C would be an indispensable modality which can improve the quality of OPCAV, decrease the operative complications in various cardiovascular surgeries, and lead to socio-economic benefit. So I would recommend just scan it. Thank you.